Welcome to the Motivational Midwife. My name's Lynn Jones, and today is the third and final part in the NIPE series where we do the whole examination. So before you start, you're going to need to gather your equipment. So you'll need a paediatric stethoscope, you'll need an ophthalmoscope, you'll need a tongue depressor, and you may need a tape measure to remeasure the baby's head. You will have thoroughly checked the maternal notes, so you will have looked at her antenatal history, if there's any medical conditions that could be of note. You will have also looked at family history. You will have checked the scan reports to see if there was anything of note in the scan reports. And you will also have looked at the type of birth she had, how the baby was post-birth. You will also have noted if there were any resuscitation was required. So after gaining consent from the parents, and they will have already had a chance to have read the leaflet and make sure that they fully understand the purpose of the examination. The NIPE examination is also a good chance to do a thorough top to toe, as well as those 4 elements that you're looking for as part of the NIPE screening. So make sure you have a nice firm flat surface to do your examination on, that the environment is warm because we're going to be undressing the baby, and that the parents can see what you're doing. So first thing to look at is the baby and how the baby's behaving. And a term baby generally is in an attitude of flexion. So the arms will be up and the legs will be bent up as well. So a term baby generally has what we call an attitude of flexion. Observe how the baby is. Is it calm? Is it fractious? You know, really, when you're going to undertake this examination, you want the baby to be calm and rested. You don't really want it to be needing a feed or screaming the place down, because that's going to make your examination extremely difficult. So we're going to undress the baby first so we can have a look at the baby in its entirety. And I always will tell the parents not to worry if I don't talk when I'm doing a part of the examination, but I will discuss everything with them as I'm once I'm finished or as I'm going through. Okay, we don't want the baby to get cold, so make sure we've got a blanket that we can cover the baby up with once we've had a good look. So we're going to have a look at the skin first of all. Is it intact? Is there any obvious injuries that you can see? Is there any obvious rashes or birthmarks that you can see? Is the baby well perfused? In the first few hours after birth, it's not uncommon to have bluish hands and feet. But the body centrally, this baby should be well perfused, and the colour should be appropriate for the baby's ethnicity. And so you turn the baby over and have a look and see if there's anything obvious. You will look in more detail as you're doing each part, but that first general look, and then cover the baby up so it doesn't get cold while you are doing each part of the examination. Often you will be opportunistic when you're doing the examination. So if the baby is quiet, you may undertake the heart examination aspect first, because you really want that baby to be quite calm and quiet, so you can have a good listen to the baby's heart sounds. But for the purpose of this video, we're going to be very systematic in our approach, and we're going to start at the top and work our way down. So we will start with the baby's head. So let's look at this baby's face. So first of all, is there anything obvious? Does the baby look dysmorphic? So do the features look symmetrical? Is there anything obvious that you're concerned about? And we'll start a gentle palpation. So We're going to palpate the mitopic suture or frontal suture up to the anterior fontanelle or bregma. This is your diamond-shaped fontanelle, and it's the average size is about 2 centimeters, but it can be a little bit bigger, can be a little bit smaller. Then you have your sagittal suture going all the way back to your lambda or posterior fontanelle, which, depending on how early you're doing the examination, you may or may not feel because of moulding. And that's about 0.5 centimetre, and that'll usually close by about 6 weeks. You have your coronal sutures coming down here and your lambdoidal sutures going from the lambda. You're also looking at the head for any hair whorls. More than 2 may be, and particularly if they are on the parietal bones, may be indicative of abnormal brain growth. You are also looking, is there any obvious signs of injury? So has there been a fetal scalp electrode? So have you got broken skin that we need to make sure doesn't become infected? Has there been a scratch from an amni hook when ARM's been performed? Has it been an instrumental delivery? Is there a chignon present from the ventouse cap? Is the skin intact or has it been broken? Is there any caput or cephal hematomas? Often the cephal hematomas are on those parietal eminences, and they may be quite small to start with. They will get bigger. It's the nature of a cephal hematoma that it will get bigger before it gets smaller. Looking at the baby's face, if you divide it into thirds, have we got sort of equal proportions? And looking at the eyes, it should be approximately from the outer canthus to the inner canthus to the other inner canthus, and inner canthus to the outer canthus should be all more or less the same, so equal distance. The eyes should look symmetrical. We should have 2 eyebrows. We should have eyelashes that are curling out. Inward curling eyelashes can cause damage to the baby's eye. And we have 2 eyes, and they are, the baby has its eyes open, so we can see that. If you draw an imaginary line from the outer canthus of the baby's eye all the way around to the lambda, the helix of the ear, so the top part of the ear, should sit no more than a third above or below. So looking at the ears, we should have a normal, complicated ear, so all its cartilage is there, and if you fold it over, it should recoil back. There should be no skin tags or lumps or bumps. There should be no preauricular sinuses, so no little holes here, and the auditory meatus appears patent. And if the baby's had its hearing test, you'll know that for certain, and obviously do the same on the other side. Moving down to the nose, is it normally situated? It's got 2 nostrils. Is there any signs of nasal flaring? So does the baby look to be having difficulties breathing? If you occlude each nostril in turn, the baby should remain a good colour unless there is an occlusion, in which case you'll need an urgent referral to the senior neonatologist. Going down to the philtrum. So we should have a nice deep groove there in the philtrum. Flattened philtrums can often be genetic, but it can be signs of other things such as fetal alcohol syndrome. The lips should be bow-shaped. Thin lips, again, particularly a thin upper lip, can be familial, but also can be a sign of some of those other syndromes, such as fetal alcohol syndrome. If you have a look in the mouth, and this is where your light source and tongue depressor will come, have a look in the mouth. Is there any obvious signs of cleft palate? Can we see any Epstein's pearls? Is there any natal teeth? Do we have any normally sized tongue? Have we got any, you can do a digital inspection as well, just to confirm that you haven't missed any cleft palate. You need to try and visualize the uvula at the back of the mouth. Is it normal or is it bifid? Bifid uvulas can often be associated with cleft palates. And then moving down to the chin. So a small chin or a chin that seems to be what we call micrognathia, so it's a small mandible, it's pulled back a bit, can again be familiar, but can also be a sign of some of the syndromes such as Pierre-Robin syndrome. Check for tongue tie and check for fontanelle. A depressed fontanelle could be dehydration, and a bulging could be in sign of infection. So the NIPE element of the examination, obviously we're looking at the eyes, and we've already looked at them generally, but we're going to now look for any signs of congenital cataracts. So you need your ophthalmoscope. Your eye will go to this side, and the other side is a nice bright white light that you can change the size of on the side, but you want a nice decent sized light there. So with the lights turned down so that you get a good response. If the baby's eyes are open, then come in from the side. Does the baby's pupil react to light? Is there any obvious abnormalities of the pupil or the iris? And if you have your eye to it, can you see a nice circular red reflex? And then do the same on the other eye. Babies of darker skin will often have a paler red reflex, but if you're in any doubt, it's always worth asking a senior neonatologist to just check your findings. A white or absent red reflex should also always elicit a second opinion from a senior neonatologist, as this baby might need a referral to an ophthalmologist. So moving on to the neck, we're having a good look at the neck. There's no evidence of torticollis where the sternomastoid muscle has become shortened and restricted. It's very often due to position in utero, but the baby then can't tilt. It tends to have its head tilted to one side, finds it difficult to turn its head to each side. So can the baby turn its head from side to side? Very often when the baby turns its head to one side, the opposite arm will come out. Make sure you're palpating. There's no masses, no fistulas, no holes, no sinuses. We're not got any webbing or any excess skin. Palpate the clavicles to make sure they are both equal and there's no obvious signs of injury. If the baby is moving both arms equally, that's a promising sign. If you do your startle reflex and the baby only elicits the startle reflex on one side, you may be looking at an injury on the opposite side. So looking at the baby's chest, does it look normal? Do we have a normal looking rib cage? Does the chest look sunken in or sticking right out? If you have a prominent zivisternum, if you palpate it gently, does it push back quite normally? If not, it could be a mass and may require further investigation. The baby has two nipples. Are they normally situated? If you palpate round them, they often feel slightly pea-sized, and that is normal, and you can reassure mother that that is normal. It's just the withdrawal of her hormones from the baby, irrespective of whether it's a male or a female baby. Is there any evidence of recession? Have you got bilateral chest rise? Can you see chest rise on both sides? There's no evidence of respiratory distress. If you put your hand across, can you feel any heaves or thrills, which is like cat purring? If you pop your hand across, you can feel the point of maximum impulse, which is your apex of your heart. And that is what we will go on to next, is the heart examination. So we are going to now undertake the heart examination. You've already ascertained there are no heaves or thrills. You have palpated to find your point of maximum impulse, and we are going to listen at the apex, which is also the mitral area, for 60 seconds. And you're listening for a clear lub-dub sound. Once you've done that, we are going to auscultate the other areas of the heart for the presence of murmurs. So midclavicular, second intercostal space on the right sternal edge is your aortic area, and you'd listen for 30 seconds. Mid-clavicular second intercostal space on the left sternal edge is your pulmonic area. And then fourth intercostal space is your tricuspid. And then if we turn the baby over, mid-scapular would be your fifth site, and this, if you hear a murmur here, it's very often reflecting coarctation. So part of your cardiac assessment is not only listening to the areas of the heart, but also palpating your femoral pulses. And I tend to find there's a natural little dip that you can feel, and if you put both fingers there, you will feel a femoral pulse. Some people do it straight on, but I find it easier myself to do it in that natural groove, and you should pick up those. If you press too hard, you're going to occlude and then you won't feel it at all. Once you have palpated them, you are looking for rate and rhythm and strength. You're going to palpate a brachial, your right brachial with your left femoral, and again you are palpating to feel equal strength, rhythm and rate in both. Pulse oximetry is also used in a number of hospitals as part of this cardiovascular assessment, and you would put the pulse oximeter on the right wrist and the left foot for pre and post-ductal readings, and you're expecting levels of 95% or above. So once we have done the cardiac assessment, we do need to really look at a respiratory assessment. We have already looked at the chest and looked for signs of respiratory distress. So we're going to auscultate the lungs. So if we can do this in an S shape, and really you're not expecting to hear any crackles or rails, no grunting. You're not expecting the breathing to be sort of difficult. You're not expecting the breathing to be rapid. You're not expecting to hear any wheezes, and you're expecting to hear equal air entry on both sides. So you can go in a sort of here, and then we've got the middle of the lungs and then the lower lungs. So looking at the baby's arms, are they of equal length? Is the baby moving its arms equally? If it's not, it could be an indication of some birth injury. If there is some brachial plexus injury, you'll often find one arm is not moving as well as the other, and sometimes the wrist is turned backwards in what's called a waiter tip. So it goes like that behind the baby. Palpate from the shoulder down the humerus to the elbow joint. Baby, does it work? Yes, there's no restrictions there. Down the radius and ulna to the wrist joint. Again, it is a hinge joint. Does that work? Has the baby got 4 fingers and 1 thumb? There's no evidence of polydactyly, so extra digits, clindactyly, where the finger sort of curls over, or syndactyly, which is webbing. 2 palmar creases are visible. A single palmar crease could be indicative of one of the trisomies. However, in the absence of everything else, the single palmar crease with no other things going on is notable, but not necessarily concerning. But again, if in doubt, then get an opinion from your senior neonatologist. The baby will often elicit a grasp reflex as well at this point. So you can see, and if you stroke the back of the baby's hand, it should open its fingers again. So looking at the baby's abdomen, does it look a normal size and shape? Does it look very distended? Can you see any peristalsis there? If you palpate all 4 quadrants, does it feel soft? Is the umbilicus normally situated? If you palpate round that, is there signs of herniation? Is there signs of any infection there? Does it feel warm? as it should do? Does it look the right colour? You need to palpate to see if there is any enlarged organs. So the liver on this side, it's not uncommon to feel the liver edge, but it certainly shouldn't be more than about 1 centimetre. And the spleen on this side, and very often you won't feel that at all. And then the kidneys as well. So the best way to do that is if you bend the infant's legs, it will relax the abdominal muscles, and then with the flats of your fingers, if you do a rolling, gentle sweeping rolling motion up, if you don't take your hands on and off because you may well miss something, and the same for the other side for the liver edge. And then to palpate the kidneys, put the flat of your hand more or less in the middle of the baby's back, and then at a 45-degree angle, gently palpate down, and the same on the other side. And if you do feel the kidneys, they very often feel like a very small plum. So then we come on to the genitalia. Obviously, if this was a little girl, we'd look for labia majora, labia minora, that she has a vagina. There is often vaginal discharge, which the parents can be informed is actually normal, and sometimes it can be blood-stained. With a little girl, I actually do palpate down the labia just to make sure there isn't a testy in there, because you could have an ambiguous genitalia. So it's, and certainly I know when I was doing my training, there was a girl in my set who that very thing had happened to when, on one of the babies she was examining, and it did turn out to be genetically a male baby, even though it looked like it had female genitalia. So it's just something to note that it is worth just doing a gentle palpate down labia. But this is a little boy, and looking for the presence of the testes is part of the NIPE examination. So looking at the penis and scrotum, do they look normal? Do they look normal size? Is the penis normally situated? Is it a normal size? Does the meatus, the urethra, is it normally situated? You haven't got hyperspadias on top or hypospadias underneath. Is there rouget, or the little sort of roughly bits on the scrotum? Is the raphe, that's the line that goes from the underside of the penis all the way down the scrotum to the perineum, is that present? Has the baby passed urine? Has the parent seen the baby passing urine? If we're going to palpate for the testes, you can do them individually, and then, but they must both be done together at some point so that you know that you're not feeling the same testy. So start sort of up in the groin and palpate down the inguinal canal, and palpate testy there, and the same there, and then to be sure that you definitely have 2 testes, and they are both in the scrotum. Now, if you can only feel one, it may be that you are able to do what we call milk the other one down, so you can feel it in the canal, and it does come down, or it may be that you cannot feel it at all, and that pathway generally is the GP will recheck that at 6 weeks, and take it from there. If it's still undescended, they may recheck it again a few months later, and if it's still undescended, then they will refer at that point. If there is bilateral undescended testes, so there's no testes felt at all, that is an urgent referral to a consultant paediatrician within 24 hours, because we do have to rule out ambiguous genitalia as well. So it is an urgent referral, so that one needs to be dealt with very urgently. And then looking at the baby's lower limbs. So I'm just going to take that nappy away for a minute so you can see. Are the baby's leg lengths equal? If we put the knees, feet together, are the knees equal as well? This can be part of the hip examination, which we'll do in a second. And again, very much like the arms, palpate down your femur for no signs of injuries, the knee joint, and then your tibia and fibia. with the feet. Is there any signs of talipes? So positional talipes, very often you will see babies, the feet bend right up. That is a positional talipes, and as such does trigger as a risk factor for hip dysplasia. Even though, as I say, if it's positional, it will go back to its original position just with you moving it. Has the baby got a plantar reflex? So when you press on the baby's foot, the toes will curl round, and if you stroke, the baby's toes will splay out. So that's Babinski. And is there any polydactyly, clindactyly, syndactyly, the same as with the fingers? Is the nails there? There's no signs of infection on any of those, as with the fingernails, and the same on the other leg as well. So doing the actual hip examination, we're going to undertake two procedures. One's Ortolani and one is Barlow's manoeuvre. And Barlow's manoeuvre is to see if a hip is dislocatable, and Ortolani is to see if the hip is already dislocated. And when I trained, I was always taught to do Ortolani first, so that if the hip is already dislocated, you are clunking it back into place. And if that's the case, Barlow is kind of negated because you know that hip was already dislocated, so you know it's a screen positive finding. Clicky hips, although you might find them, they tend to be more ligament based, and they're not part of the NIPE screening program, and so they'll be dealt with as per your local trust policy. So make sure that this is Alice sign. Have we got equal knee length? Creases, equal creases used to be part of the examination years ago, but that's been moved from it now. So if we haven't got equal creases on when you turn the baby over, that's no longer part of the hip examination. So in order to undertake your hip examination, and they should be done one at a time, it's poor practice to do both together. You want to stabilize the hip, so have a thumb on the pubic bone and your other fingers behind the baby's pelvis. Put your two fingers on the greater trochanter, and then we'll do Ortolani first. So you are coming in and round and out, and it's at that point you will hear the clunk if there's going to be one, and then bring it back in, and then repeat on the other side. And then for Barlow's manoeuvre, you are same hand position, but you're coming into the midline and you are telescoping down. So you're trying to see if that hip will dislocate out of its socket. So babies that are obviously more likely to have that are your breech babies, family, first degree relatives that have had that, babies that are one of a multiple birth. If one of them are found to be screen positive, they should all be screened, or if any of those multiples were breached, then all babies should be offered the ultrasound scan and a 6-week appointment just to be sure. So having turned the baby over, we're completing the skin examination. So is there any evidence of birthmarks? Particularly in babies of ethnicity, you will often see blue pigmentation across the buttocks or sometimes on the shoulders and arms, and it's important that these are documented accurately because they can look like bruises. Is the hairline normal? Is there any when you're palpating down the spine, is there any evidence of kyphosis, which is where it's sort of humpback, where it's sticking out, or scoliosis, which is the curvature of the spine? Is there any sacral dimples that you can see? If there is, can you actually see the base of the sacral dimple? Is there any hair tufts? These could be linked to spina bifida occulta. So it is important that if you're unsure, that you do get a review by a senior neonatologist. Buttocks, as I say, this is normally where you would see often a lot of those pigmentation. Is the anus normally situated? Is it patent? If the baby's past the meconium, you know that it's clearly patent. Is the perineum normal for that baby? Is it there? Can you see breathing, bilateral chest rise? No signs there of any abnormalities. And it's a good time at that point to listen into that mid-scapula for your coarctation. There are a number of reflexes that are primitive reflexes that are present, and depending on your trust, they may or may not check for some or all of those. The startle reflex or Moro reflex is probably the one that most people know, where you hold the baby and you gently drop the baby back into your other hand, and the baby will startle. Hands will go out and then they'll come in and go out again, and that's a normal reflex. However, me personally, if I've inadvertently bashed the cot when I've been coming towards the baby and the baby's already startled, I won't do the startle reflex again because I've seen that it's startling. The baby also has a stepping reflex, so if you hold the baby up, you won't see it particularly well, but the baby will step. The baby will have rooting, sucking, gagging, swallowing reflexes, palmar grasp, plantar reflex. And I think I said earlier, if the baby has a fencing reflex, so if the baby's head turns one way, the opposite hand often will shoot out as a reflex. And there's the gallant reflex. So if you hold the baby and you stroke down its back, it will often do a sort of curve like that. And that reflex is said to help in the baby's crawling. So in conclusion, we make sure that we have reviewed the notes adequately and any scans, that we have got detailed family history, that we have got a warm environment on a firm flat surface to undertake the examination, that we have all the correct equipment available to us, that we have gained consent from the parents, that we make sure the parents are fully involved in the examination and decision making, that we explain everything, all our findings to them, that we document in the NIPE Smart system and the Trust baby notes, or whatever trust systems your trust has. And we need to make sure that the parents know the next step. They also need to be aware of signs and symptoms to warrant further investigation. And there you have it, NIPE. I hope you found the 3 videos useful. If you haven't subscribed to the channel, please do, and I look forward to seeing you next time.